Hello, everyone. Good morning and welcome. This is our webinar that's going to focus on approved and investigational treatments for AL amyloidosis. I'm Muriel Finkel, and I'll be your host today. Now, you can view this webinar about 1 or 2 weeks up on our website, amyloidosissupport.org, and on our YouTube channel. And that's where we put all of our webinars, so you can watch previous ones as well. Filling in for Bob Gibson today is ASG's Assistant Special Projects Director, David Jennings. David, say hi.
Hello, everyone.
And joining David in the control room today, we have our Executive Director, Paula Schmitt.
Good morning, everybody.
Okay. Some of you sent in questions ahead of time, and we'll answer those first. Our esteemed panel will do that. And if we don't have time for all your questions that are typed in during the webinar, we'll ask our esteemed panelists to respond to them, and then we'll send you out the responses. The chat portion has been disabled, but there will be occasional useful items popping up posted by Paula. Our panelists today include Dr. Heather Landau from Memorial Sloan Kettering. And we have Dr. Nelson Leung from the Mayo Clinic. And Dr. Robert Vescio from Cedars-Sinai. He got up nice and early today. He's on the West Coast. Along with Paula Schmitt, who'll be filling us in on the latest financial aid news. There'll be a brief survey when this meeting's over, and we do ask that you take the time to fill it out. And if you have to leave early, we want you to fill it out when you leave. If not, I will send out a link, but it's really important that you fill out those surveys because they help us in designing future webinars. We'll be working off our treatment chart today. And David, can you put that up on the screen so that there you go, so that people can reference it. Paul is going to put up a link for you to have that, and so you don't have to worry about taking a picture of the screen. And if you want a copy of that as well, email Muriel at amyloidosissupport.org, and we'll get you out a copy. I'm sure the doctors will be they'll have their own version of these charts, and they'll be referred to them when they do their presentations. We're not going to show the animated video today, but if you want to watch that and download our booklet, you can go to amyloidaware.com or send me an email and I'll send you a link for that. Okay, so now let's get started right away. Okay, and we're going to hear about standard of care, stem cell transplants, and the more common therapies from Dr. Robert Vescio from Cedars-Sinai, the Center for the Stars. Dr. Vescio, take it away.
All right. Well, thank you very much for allowing me to talk about amyloidosis. It's a very interesting and important disease to recognize. And I think, as you'll see, there's a lot of progress that's been made. So I'm going to go kind of quickly because we don't have a lot of time, but I'll start at the basics. And all our blood generally is made inside our bones. In the middle of the bones, there's a space, and that's where we make all our blood cells, the red blood cells that carry oxygen, the platelets that stop us from bleeding, and the white blood cells that help fight infection. Each one of those blood cells has a different role to help us survive. So the disease or the cell that causes problems for amyloidosis is called a plasma cell. And a plasma cell is a cell of the immune system. And its basic job, its entire job, is to produce an antibody, produce antibodies to help us fight infection. And each plasma cell makes a different one. We have millions of different plasma cells in our body. But when we get exposed and figure out how to fight an infection, there'll be a growth of a plasma cell. And when there's a bunch of them making antibodies to bacteria or virus, it helps our body so we can fight off that virus, fight off that bacteria. And they live a long time, so we hopefully don't get an infection a second time. So unfortunately, what happens when people have AL amyloidosis, and that's what we're going to focus on this morning or right now. Just one of those cells gets a mistake in the DNA, in the instructions inside the nucleus of the cell, and that single mistake makes it misbehave and start to grow. And often there's additional mistakes that occur, but the concept is some of these mistakes, instead of making the cell die, it forces a lot of traffic down the wrong lane. So one of the mistakes that's common in amyloidosis is the 11-14 translocation, where one part of the chromosome switches to the other, and you would have all this traffic on one of the freeways out here going down a side street where there's little genes, there's little shops, and that would overwhelm, it would mess up the overall function of the cell. So when there's these growths occur, they can occur in a way that's not harmful, and that's called MGUS. MGUS is when there's a growth of one of these plasma cells into a clone, but it's not enough, there isn't enough of it, or it's the body's able to stop it where there's no symptoms that are happening. And it's actually pretty common. I've never had my blood checked, but if you just take people 50 years old, about 3% will have the precursor to multiple myeloma, or kind of a precursor to amyloidosis if you look for it. Multiple myeloma is the related condition, and this is when the cells truly behave like a malignant cell. They're behaving cancerously. Usually people come to the hospital or come to the doctor's office because they have symptoms. They harm the bones, and cause them to break, or they grow so much they crowd out the healthy bone marrow and make people anemic. So that comes to amyloidosis. So when we're talking about amyloidosis, that's a condition where the protein, either the kappa or lambda light chain made by the MGUS, the non-cancerous, or the actual cancerous cells, the myeloma cells, accumulate in the body, and the protein causes the organs such as the heart, the kidneys, or the nerves to not work right. So for the heart, people get a thick heart and heart failure and arrhythmias. If it's the kidneys, it makes the kidneys leak normal proteins, so people get swollen legs. If it's the nerves, people get tingling, burning in their hands or feet. If it's the intestines, and this is a problem, their intestines don't work well, they have a hard time swallowing, food doesn't pass through like it should. And actually, it turns out that the actual structure of the protein determines whether the MGUS-like growth will form amyloid or it won't. So it's just by the molecular structure of the kappa or lambda light chain determines if these proteins will build up and cause a problem. So the goal, the main thing that needs to happen with amyloidosis is we have to get rid of that clone, because that's the problem. And if we can eliminate the clone with whatever therapies, medicines, drugs that will kill it, then there won't be any of those cells left in the body, or at least not many of them, and therefore there won't be that abnormal kappa or lambda light chain in the bloodstream, and the disease won't get worse. But actually, and what isn't always obvious, and I will say many of the doctors, I know the residents don't always understand this. It's one of the first questions I ask them. The question is, can you get better if you destroy the clone? Will the amyloid protein reabsorb, and can people improve? And almost always the residents tell me no, but at least they won't get worse. But actually, usually the body can indeed break down the protein slowly over time, and the heart, kidneys, nerves can eventually get better and function better. And there's other things, that other treatments they're trying to focus on, trying to help remove that antibody and make that process faster. So you saw this slide already. Here are the drugs that are available for us to use. Some are still being investigated, but these are the drugs that we have available to kill those cells, basically. So there's a lot of them, and given the fact that there's all these choices, I'm sure a question is, well, why do we choose what we do? And in the bottom is the Dara-Cybor-D. That's the typical regimen. I'll go through that here in a few minutes. But I want to talk a little bit about steroids. A lot of times people, when they take steroids, the steroids that are used to treat asthma and reduce inflammation, like dexamethasone and prednisone, people aren't sure why you take these steroids. And it's because they also can kill the plasma cells. I had a patient, one of my first patients with amyloidosis, 87 years old. When I met him, big swollen legs, his kidneys were failing, and he was pretty frail. And I just gave him steroids because at the time we didn't have much else. And that put him in remission. And he eventually passed away of old age in remission with normal kidneys 4 years later with just the steroids. The problem is the steroids have their side effects, clearly, and often are the most bothersome medicine. Make you gain weight, make people a little irritable, make you retain fluid, cause cataracts. It can do lots of things. And what's important to know is it's amazing how different people tolerate the drug. So some people are very, very sensitive to it. Other people can take 40 milligrams of dexamethasone and sleep like a baby and don't notice anything. So you have to help your doctor know how you're tolerating it. The other tool that we have are just the classic chemotherapy drugs, and they've been around a long time. And to be truthful, it's like giving a poison. They're poisons that kill things that grow fast. Healthy blood cells tolerate this type of drug better than the cancerous or precancerous cells. And so that's why we use it. And in fact, melphalan is the drug we use for a stem cell transplant. So what is a stem cell transplant? So sometimes, not always, we will give treatment before the transplant to try to control the disease. And that's called induction treatment, where people take a few months, 6 months of treatment to try to kill many of the cells. But if it's time to do the transplant, what we do is we have to collect cells from the bloodstream that will be able to regrow the bone marrow. And they're not normally in the blood, so we have to give shots, GCSF shots, to tell the bone marrow to put out the blood stem cells, put them into the bloodstream so we can harvest them. It's kind of a weird name, but for those in the Midwest, you know all about it. So you harvest the stem cells, and then we collect them and freeze them alive so they are in a tank, frozen but still alive. And then the actual treatment is the chemotherapy. That's what's doing the work. And we give a big dose of melphalan, kind of enough to make people sick, but hopefully not too sick. And that's the understanding is that's going to try to kill everything in the bone marrow, good cells but hopefully more importantly, the bad cells. And then the drug gets out of the bloodstream very quickly. So the next day, we can put the stem cells back in, and in about 10, 11 days, the blood cells grow back the bone marrow recovers, and the side effects of the transplant hopefully are less. And then hopefully it worked really well. And then sometimes we give, even if it worked well or if it didn't work as well as we wanted, we will give some type of after transplant treatment, particularly if somebody has both multiple myeloma and amyloidosis. If they have the cancerous forming cells that make amyloid protein, then we're more worried. We don't want to give the cells a chance, so we give treatment afterwards. The problem with the stem cell transplant, it sounds great in theory, and it is very effective, and I have people that truly were cured by this single procedure. But the problem is that's not most. So if you just do it straight away, only about a third of patients get cured. And one of the questions I always wondered, and many did, is, well, why, when we treat people without amyloidosis that just have multiple myeloma, we will give treatment to debulk their disease first, and then when their cell numbers are less, then we would do the transplant. And oftentimes people feel better at that point. And I think that's often the best or better way to do it nowadays. The other thing is not everybody can tolerate this big whammy, this big dose of melphalan. The other problem is people do lose their hair, and this is kind of a plug, but we did a study here at Cedars-Sinai where we treated people doing a transplant, and we had we put a device on their head to keep their ice cold. And although the two people on the top lost some hair, pretty much everyone else, you can see before and after pictures, didn't lose significant amount of hair at all. So that's something that hopefully we don't have to worry about in the future. So in the past, a long time ago, this was a treatment for multiple myeloma, and this just is showing you that a long time ago, we gave this for patients here at Cedars for their amyloidosis. And actually about half the patients without a transplant went into remission. The problem is people were a little more likely to relapse. The transplant, when it worked, was more durable. But Dr. Cohen from up north in Seattle, they showed that if you gave some treatment first, induction first, you gave treatment and then did the transplant, the chance of staying in remission on the top was better than if you just straight away did the transplant. And these are old data, as you can see, so I show a few curves like this, but remember, things are improving. So now we have a new drug, daratumumab, and it's an antibody that sticks to CD38. CD38 is found on plasma cells, and that coaxes the immune system to hopefully kill the myeloma cells. It's a very effective treatment, and so it was combined with that regimen you saw earlier, the Cy/Bor-D, which is the 3 drugs, and most people respond. 96% of people had some type of response, and a half went into remission. And you can see many of the people that underwent this treatment, their kidneys, their liver, their heart got better. And often it stays under control. And in this particular trial, at 5 years, 60% of people still hadn't shown any sign of a disease returning. And in fact, it's now the FDA approved and basically our typical approach for most people with this amyloidosis. Not everybody responds, and this is a study from the Mayo Clinic who do great work for treating patients with multiple myeloma. I keep saying it, with amyloidosis. But you can see on the left, these were the individuals who, in their studies, were not fully responding to the daratumumab and the Cy/Bor-D, but yet when they switched to something else, many times a transplant or sometimes some of the other drugs, most of the patients ended up responding. We went into the light, into the blue or the green, where they're having very good responses to treatment. So just if it doesn't work, we still have many options. And just to throw this out there on the top, this is their survival for patients who started off with the daratumumab and Cy/Bor-D. So it looks like, and I think this is the reality, is if you get through the first month or first year or two, your chances of staying in disease control and having your disease not harm you, not hurt you, not cause you to die, is your chances are excellent that you're going to do well. So what happens if it is refractory? Well, we like to have everyone in remission. That's the goal. That's what we try to accomplish. But sometimes it's okay to have a little bit of the disease left. And that's hard to know for sure. It's subjective, but sometimes people still have a little bit. I have people like this where they're not quite in remission, but their kidneys got better and they have they've off treatment, they feel well. And so I just watch them. But if you can easily put somebody where their disease is not detectable, then that's probably is best. unfortunately, sometimes the disease relapses. And one thing to know, when if it does relapse, usually people feel better by that time because their disease got better. It maybe started to come back by the lab tests. And then generally people are in better shape to tolerate treatment. And there's a drug that everyone needs to know about. It's called venetoclax. And if people have an amyloidosis, about half do, that have that mistake where 11 and 14 cross, it's an extremely effective drug for people with amyloidosis. So these are the drugs, just kind of going through them. Bortezomib, Velcade, it's a shot. It can cause neuropathy. It can cause burning, tingling feet. You have to let the doctor know that. It can cause styes, which not everybody kind of would think about, and it can cause some diarrhea. There's other medicines you can see here that are sometimes given. Ixazomib and Larrow is a pill. Maybe doesn't work as often, but it's obviously more convenient. There's the IMiDs. They work. They work to. They're a pill, and they work by boosting the immune system and suppressing some of the hormones that the amyloid cells need to grow. They have their issues. Kind of all of these drugs have some side effects, but that doesn't mean you're going to have them all. Many people have none. Some have a lot of them. Finally, there are people that unfortunately really weren't diagnosed very early, and they present with their heart not working and life-threatening heart failure. And we started doing a heart transplant first and then treating the amyloid afterwards. And we've had even sick patients like that. We've had good luck in having people survive the experience and have their disease controlled for decades and more. So the goal, if you have AL amyloidosis, is to get this kappa or lambda light chain into the normal range, because whatever the amyloid cells make, that's the harmful protein. And there's different ways of measuring it. You could almost have a whole lecture on how do you measure the light chain, but basically you want the bad one no higher than the good one, or certainly not much higher. And we can do a bone marrow biopsy to make sure there's no disease left in there. But importantly, and this isn't always clear to everybody, is that you can get better, but it takes time. It doesn't happen right away. The drugs can work, but then months later, hopefully, you can start getting better. And I would say amyloidosis is typically or often curable. So I think we can, with the drugs we have now, cure or at least control. So you'll have to be watched, but hopefully the disease won't ever come back, or if it does, we just treat it again. I think transplants are less likely to put somebody in remission as a single treatment, but when it works, it can be curative. It's important to know for insurance that if that original bone marrow biopsy had 10% of the cells being the bad ones, the plasma cells, then you can be labeled as having both multiple myeloma and amyloidosis. And that is helpful because not all these drugs that you saw earlier are approved for amyloidosis. And then finally, what I would say, there are a few people that have an IgM making clone. They're more like a lymphoma or Waldenstrom's, and there's different drugs for them. And if you get through the first few months, that's really the hard part, because you're sick usually, and you're taking treatment. It's going to make you not feel well. But then once you get through that, usually people do better. So I'll stop there.
Thank you so much. I love your optimistic presentation. That was really
Okay.
great. Thank you so much, Dr. Vescio. And we'll be back to you during the Q&A for sure. And now we're going to hear about, we saw on the chart that there were other treatments, some new novel treatments, bispecific, CAR-T, Anti-Fibril, and we'll hear about those from Dr. Landau. So Dr. Heather Landau, take it away.
Thank you so much for having me. I'm trying to share my slides.
There you go. Perfect.
Okay, and thank you, Dr. Vescio. That was an amazing overview of the biology and the treatment options that we have at present for patients with amyloidosis. And also, yes, I share his optimistic view. So now I'm delighted to share emerging treatments for patients with amyloidosis. So as we heard that we do have one approved treatment for this condition, the DARA-CyBorD regimen, which was approved and very effective, and 60% of patients will get into this very deep remission. But that's the only treatment option that we have FDA approved. I list here all of the drugs that are approved for multiple myeloma, the standard of care drugs that are approved for multiple myeloma, and there's lots of emerging new immunotherapies that are now approved for multiple myeloma. And I just wanted to spend a minute to talk about these new therapies because, as you heard, the plasma cell is the abnormal cell that causes the production of these immunoglobulins that ultimately form amyloid. But these plasma cells also express these markers. BCMA is one of anti-CD38 is one of the markers that is what the daratumumab is directed against. There's also this BCMA protein that most abnormal plasma cells express, and we can target that with different therapies, and that has led to a whole new class of drugs for both multiple myeloma and now amyloidosis, and they're being studied in amyloidosis. And I just wanted to spend a minute to share with you these different therapies we can target, and I'll go into this more specifically, but we can target these abnormal, these proteins that these plasma cells express by either something called CAR T cells or chimeric antigen receptor T cells, or this bispecific antibody where one antibody binds to something on the plasma cells and one part of the antibody binds to something to the patient's own T cell, and these T cells help target these plasma cells and get rid of these abnormal plasma cells. Or there's other kinds of antibodies where we can target the BCMA protein or another protein on the plasma cells and deliver a drug specifically to these plasma cells. And so this is a whole new way we target plasma cells, and there are several different immunotherapies that are in this using these kinds of approaches, and those are what I'm going to talk about today. In addition, we have these amyloid-directed therapies where antibodies are directed not to the plasma cell, but to the amyloid that's deposited in the organs. But we have to also know that these novel therapies have unique toxicities that we have to deal with, and I'll talk a little bit about that as well. So what are chimeric antigen receptor T cells? This has been a groundbreaking approach in the treatment of hematologic malignancies in general. And because of the impressive efficacy against the BCMA target that I just talked about, in relapsed refractory multiple myeloma, we now have 2 approved products with response rates that approach almost 100% and complete hematologic response rates that approach 80% with certain products. But we also know the BCMA is expressed on amyloidogenic plasma cells. So the amyloid plasma cells also express this, and it's also retained when patients are relapsing. So how do these CAR T cells work? We take a patient, and Dr. Vescio beautifully explained um, how stem cell transplants work. It's similar, but in terms of we have to collect your cells initially. And those T cells then go to a laboratory where they're engineered to have this antibody that's directed against the protein that I described, the BCMA protein. Those, but those are your own cells, engineered. They're expanded in the lab, and then they come back and they're infused back into the patient, and then these specific cells can target the abnormal plasma cells, and these T cells are destroyer cells, and they can kill these abnormal plasma cells, lead to plasma cell death. And that's one way to get rid of these abnormal cells that Dr. Vescio explained are the culprit for producing the amyloid. And if we can get rid of the culprit and stop the production of the amyloid, then patients can get better. But these CAR T cells have unique toxicities. If we stimulate it's an immune therapy, and it can cause something called cytokine release syndrome or immune effector cell neurotoxicity. And because they are so powerful against plasma cells, both normal plasma cells, both the abnormal plasma cells and the normal plasma cells, and you heard from Dr. Vescio that these plasma cells are important for fighting infection, they can also lead to infections. But the CRS and the ICANS are things that are expected after mostly the cytokine release syndrome, where because we're stimulating the immune system, often after we give the cells, patients will have a temperature. That is something that is common, and we often treat with antibiotics because we don't know if it's an infection versus the CRS, but we also treat with a medicine called tocilizumab, and it's very effective. So oftentimes this doesn't escalate. We have a grading system for higher grade CRS, because if we allow this to continue, you can get a temperature, and then you can get low blood pressure, and then you can need more supportive care, even ICU type level care. But oftentimes this will be managed very effectively with just this medicine called tocilizumab that just dampens down this response. The ICANS is this immune effector cell associated neurotoxicity, where patients can get confused or delirious, or even need ICU level care. And that is something that's also very manageable with steroids or these medicines that dampen down this immune type of response. But oftentimes that happens in patients who have a large burden of disease. And in patients with amyloidosis, we often treat patients usually have a very low burden of disease. So these types of toxicities are often not very robust in patients with amyloidosis. So we did the first trial of CAR T cells with a product called NXC201 in relapsed refractory amyloidosis. Because this was so powerful in multiple myeloma, and because patients have such a low burden of disease, and actually in the relapse setting, as Dr. Vescio explained, patients even who were very sick initially are usually less sick when they have relapse disease. And so we use this treatment, and we just presented our initial data of our phase 1 results, where we treated 10 patients in a dose escalate, and first at a lower dose and then at a higher dose. And because there was no significant toxicity, we've now expanded into a phase 2 program where we have treated now up to 25 patients. And we have 15 more patients planned for this therapy. And hopefully we can bring this to the FDA because of the significant efficacy and really good safety profile that we've seen. I did present this data a couple of months ago at a conference where we showed our first 10 patients that I'll show you here, where we treated patients up to 82 years old. Many patients had received several different lines of therapy before, but still had persistent disease. 70% of our patients had had heart involvement. At least one patient had very advanced kidney disease, which with a high creatinine and a high burden of protein loss. And what we saw is 80% of patients had this cytokine release syndrome that happened, but it was very low grade, and it only lasted 1 day in the majority of patients. It was very effectively controlled with that medicine, and nobody so far has had any neurotoxicity of any kind up to our first 25 patients. So I think that with a low burden of disease, this can be given very safely. We did the one patient who had advanced kidney disease, was becoming more advanced and did have more advanced kidney disease and end up requiring dialysis, which was really not unexpected for the patient who was heading towards dialysis even before the treatment. We did see some infections that were manageable. The one patient who required dialysis did ultimately recover from her treatment, but then several months later had a dialysis catheter-related infection, which was unmanageable, and she succumbed to that. But what we did see, which was very encouraging, that all of our patients normalized their abnormal cells within 7 to 14 days, and their protein in the blood actually within 7 to 14 days. And the majority of patients have had a hematologic response, even our patient who had the advanced kidney disease. And so 70% had a complete hematologic response. 3 patients, so when we get rid of these plasma cells very effectively, there's one blood marker, the immunofixation, which doesn't go away as quickly as the free light chains normalize. And so 3 of our initial patients had no disease in the bone marrow, but still have this marker in the blood that we expect to go away. We did have this one death unrelated to the treatment, but related to a catheter-related infection in somebody on dialysis, and nobody has relapsed to date. So we're really encouraged by these results. The one thing I wanted to share is one patient, in her own words, it's not only that the response from a hematologic perspective was good, but patients really feel better. And one of my patients wrote this to me on day 15. She said, "It's only been a week since I left the hospital. After those magic CAR T cells, I've been very comfortably walking 2 to 3 miles a day, even on inclines." she never thought she'd be feeling this strong and vibrant just 15 days after her CAR T cells, or ever feel that she'd be experiencing less horrible leg fatigue, shortness of breath, and chest tightness that was really increasing and weighing her down for months preceding this. This is somebody who had 2 stem cell transplants in the past. She said, I know you said that CAR T cells should be easier than stem cell transplant, and that has proven to be more accurate than I could have hoped. So it's really very effective and very manageable treatment. So we're really encouraged by this result. Bispecific antibodies are another one of these immune type of cells. Again, these are antibodies, that do similar things than the CAR T cells, because but inside your own body, these antibodies are directed against the abnormal plasma cell, as well as your own T cells within your body, and bring those together to cause the plasma cell death. So it works similarly, just a different avenue to get there. And there are 3 FDA-approved bispecific antibodies for multiple myeloma that have, again, high response rates, high complete hematologic response rates, and that has prompted this to be studied in amyloidosis. They also have a similar toxicity profile, again, because they're doing the same thing, using your own immune system to kill the plasma cells. And the difference between bispecific antibodies and the CAR T cells is a one-time approach. You give it once and then no other therapy thereafter. Bispecific antibodies, you give step-up dosing in the hospital because of this risk of cytokine release syndrome or immune effector cell neurotoxicity initially, but then you continue to give treatment in an ongoing fashion like most of our other therapies. And infections, again, because these target the plasma cells, both normal and abnormal plasma cells, because it's an ongoing therapy, we often worry about ongoing risk of infections. And this has been effective in multiple myeloma, and there has been retrospective data from 3 different groups, 4 now, showing a few patients who have been treated with these different products, and all of them have very good results. All of them achieved with different products, teclistamab or elranatamab. Again, at least most patients had at least a VGPR. Almost 70% had a complete response in the data that has been available to date. Most patients, again, get the CRS. In 2 of these data sets, there was no immune effector cell neurotoxicity. There was 1 patient so far that's been reported with some neurotoxicity. And gratefully, this is being studied in several different clinical trials. These different products, it's very difficult to compare these different products one to another at this point, and it's difficult to compare these products to the efficacy of CAR T cells for this disease at this point. They're different therapies. These are available without being engineered. These are off the shelf, but they're ongoing therapy. The difference is the CAR T cell therapy is a one-time approach, one-time treatment. And I think that I'm hopeful that both will eventually be available to patients with amyloidosis. Other immunotherapeutic approaches, there's something called belantamab, and other drugs in this category are being developed where it doesn't rely on the T cells, but it's an antibody that is against again, at least this drug to the BCMA target, and it specifically delivers a chemotherapeutic agent to the cell by binding and delivering this cytotoxic payload, resulting in plasma cell death. And the drug belantamab has a little bit of a challenging history, but it was approved, and now it's not approved, but hopefully it'll become approved. And for multiple myeloma, and there's been retrospective series reported and one prospective trial in AL amyloidosis, which had very good response rates and high, very promising response rates. The one thing that it does have is a unique toxicity that causes blurred vision, which can be kind of obnoxious, but the good news is it's really reversible in 100% of patients. So it's manageable, it's obnoxious, but it's manageable, and with different dosing strategies, we're really getting very, and with prophylactic exams to see that patients don't have these toxicities, we can really manage this toxicity, and it is going to be studied in the upfront setting in patients with amyloidosis. And as Dr. Vescio explained, although we can get hematologic response, this is a patient so had a free lambda, and you can see this is in 2008, her free lambda was controlled. She actually had a stem cell transplant and didn't respond, but then got Velcade-based therapy and did respond, and she has not had any treatment since 2008. And her hematologic disease, this is the normal range of the lambda, has remained in the normal range. So she's had a hematologic response, which is necessary but not a guarantee for organ response. Oops, sorry. She had 20 grams of proteinuria to start, but the good news is that over time, meaning months to years, so this is 2008. This is when she went into remission, had 21 grams of protein. It took 6 years for her protein to become her protein loss in her urine to be under 1 gram, and 10 years for it to be not detected. Her serum albumin was very low to start, and it took 4 years for that to normalize. So the one thing I can say is a hematologic response is good, but sometimes organ response takes time. The median time to best kidney or cardiac response is really 2 years. So supportive care is really essential for patients. And we're looking at drugs to try to facilitate organ recovery quickly, and that's by the drugs that have been studied are these amyloid-directed drugs. There's been 3 different drugs that have been studied. Actually, another approach that was developed in the UK that was initially studied as well. And I think the bottom line is that these drugs have been studied. There's one drug, the ansilimumab, that is still being studied in this way. It hasn't been a panacea. We've targeted these amyloid proteins in the the amyloid deposits, and so these antibodies target the amyloid proteins in the tissues and use your own immune system to clear the amyloid deposits to really facilitate organ recovery quickly. And one of these trials are still going on, but unfortunately, the two other drugs have stopped development because the trials have been not effective, or it has not been shown to make a huge difference in patients. So we're trying to see if this last drug has some efficacy. There's some reasons to think that now that our drugs are really good at clearing at getting people into remission, and our bodies are getting better at recovering, that maybe these drugs don't make a huge difference, but we will see over time whether this antifibril is effective for some, at least a certain number of patients. My final thoughts is nothing replaces the importance of early diagnosis. If patients are diagnosed early, then their organs are in better shape. We can treat them more effectively, and they have the best chance of recovery. So one of my main goals is to really educate the community about recognizing this condition and getting it diagnosed and getting patients treated quickly. Participation in our clinical trials is really essential. There is no way we can get these drugs approved. And now I think we will eventually, we are studying very effective therapies, and I'm excited for what is to come. I really think that there is a bright future ahead for patients with amyloidosis. And that's what I have for you today.
Thank you so much. Another optimistic approach. It was very, very wonderful to hear all the wonderful things that are happening, and a lot of hope for everybody. I have a quickie question. You're very enthusiastic for obvious reasons and well-deserved reasons on the CAR T cell, but what is the durability of this? What are you seeing?
Yeah, so our first patient was treated in June of 2024, and she's in a complete hematologic response, and she hasn't had none of our patients have progressed. Let's put it that way. And our longest patient is, we're now approaching our 3 patients. We treated everybody. We treated our first patient in June. We had to treat everybody a month. There had to be a month in between, so June, July, August. So patients 1, 2, and 3 are now at a year without any evidence of progression.
Okay.
Nobody has progressed.
That's wonderful news. Thank you so much. And
But, I can't speak to years of durability because we've only done the trial a year ago. I do have other patients who were treated in, at least one other patient who was treated with commercially approved the myeloma treatment, and he's 2 years out, 2.5 years out, and still in remission.
Oh, that is good news.
Sorry, 1.5 years out. I'm wrong. 1.5 years out and still in remission.
Okay, well, we'll watch for that. Thank you. Okay, and next we have from the Mayo Clinic, the world famous nephrologist, Dr. Nelson Leung. Take it away.
All right. So thank you very much for having me. And thank you, Dr. Vescio and Landau, for preparing everyone for my talk. So you heard this morning about the different types of therapies which targets the plasma cells, and Dr. Landau even touched on therapies that may target the amyloid fibrils. But despite this, sometimes the organ, especially the kidneys, can continue to fail, and that's what I'm going to talk to you about today. So as you know, amyloidosis is a systemic disease. What we mean by that is that it can affect multiple organs, And in AL amyloidosis, the organ that is most affected is one of the organs most affected is the kidneys. Depending on the study, sometimes the kidneys are more common, sometimes the heart is more common. But it's definitely heart and kidney are the most common organs affected by AL amyloidosis. And as Dr. Landau said, while we have very effective therapies now to kill the plasma cells and control the light chains from forming, unfortunately, sometimes the kidneys have sustained too much damage, so that even when effective therapies, the ones that Dr. Vescio and Dr. Landau talked about, had taken place, the kidneys can continue to fail. And these are two studies. The study on the left is one from the Mayo Clinic. The one from the right was from Boston University. And as you can see, despite the fact that these patients are living, so that suggesting that the therapy for their AL amyloidosis was effective, they continue to lose kidney function. So over time, more and more patients became dialysis dependent, which means that these patients need renal replacement therapy in order to continue living. So we'll go over the different types of renal replacement therapy. The first one is dialysis. And I know this is a bad word, but we do have to talk about it because many of the patients that develop renal failure will require dialysis. Now, there are advantages and disadvantages to dialysis. So the biggest advantage is that it is available almost everywhere. Especially in the United States, there's not too many places that you cannot get dialysis. And almost anyone can get dialysis these days. We have dialysis modality that can even dialyze very sick people. Obviously, there are some people that may not be eligible, but almost everyone can get it. The disadvantages from dialysis is that it does not replace the kidney. So what dialysis does is that it cleans the blood, but it doesn't replace all of the function that the kidney does. And maybe because of that, fatigue is a major issue. Fatigue is a bigger issue for patients undergoing hemodialysis, which I'll go over in a little bit. Less so for peritoneal, but it is an issue that we can't fix except with a kidney transplant. So there are two modalities of dialysis. One is called hemodialysis, where we take your blood out and run it through a machine. The machine cleans the blood, and then we put it back. The other is called peritoneal dialysis, where we have a catheter that is inserted into your abdomen, and fluid is infused into the abdomen. We keep it there for a period of time, and then we drain it, and that's how this method cleans the blood. And I put these two pictures on there to show that these catheters are actually pretty discreet. If this gentleman had buttoned his shirt, you would never know that he has it. Obviously, with the midriff shirt, you're going to see the catheter, but if she had a normal t-shirt, the catheter would have been well hidden underneath even just a normal t-shirt. Now, let's compare the differences between hemodialysis and peritoneal dialysis. Hemodialysis, there are two different forms. One is called in-center hemodialysis, where you go to a dialysis center and someone there will dialyze you. You sit in a chair, and a nurse and a technician will put you on dialysis, and then when they're done, they'll disconnect you, and then you go home. The other form of hemodialysis is the home hemodialysis. This is where a machine is delivered to your home along with the dialysis supplies, and the patient is dialyzed at home. Now, The one major distinction is that for home hemodialysis to occur, a helper is required. You cannot dialyze yourself with home hemodialysis. The advantage, however, is very flexible because in-center hemodialysis is like going to a job. You have to get there at a certain time, 3 times a week, and it is really like going to work. Whereas home dialysis, you can dialyze at any time. Generally speaking, home dialysis also is better for the patient because we dialyze more often. Most people on home dialysis dialyze 5 times a week. They don't dialyze as long, but they dialyze more frequently, whereas in-center dialysis, they dialyze 3 times a week for longer periods of time. Peritoneal dialysis, on the other hand, there are also 2 types. There is one called the CAPD, and basically this is a method where you do manual exchanges. So you manually infuse the fluid into the abdomen, and then when it's time to drain, this is also manually done, meaning that the patient does it or someone does it for the patient. There's also a form called the cycler. In this case, a machine will infuse the dialysis fluid into the abdomen, and then after a period, it will drain it, and then it cycles this several times throughout the night. That's why it's called a cycler. So in this case, the machine does all the work. Peritoneal dialysis are generally pretty flexible. When patients travel for in-center hemodialysis, you usually have to make arrangement for a dialysis center near the town or the city that you're traveling to and get a seat there, get a chair there. For peritoneal dialysis, what happens is that the patient will contact the dialysis company. They ship the dialysis fluid to wherever they're going. Patients who are on the cycler, they'll bring the cycler with them on the plane. And once they get to where they're going, they can perform dialysis there. Now, so one patient actually went on a world cruise on peritoneal dialysis, and the dialysis company actually delivered a pallet of dialysis fluid for her for the entire time of the cruise. One of my patients liked to go camping, and fortunately he uses a cycler, so the cycler needs electricity. He actually did it in the back of his truck. He plugged it in the back of his truck, but you can also convert to CAPD during these times. So in a way, peritoneal dialysis is much more flexible. For those who are more active, peritoneal dialysis may be a better choice. Of course, the best choice of renal replacement therapy is kidney transplantation. Now, there are advantages, but there are also disadvantages. The advantage is that it is a kidney. It does everything the kidney should do, and so it's like having a kidney again. The quality of life is much better because you don't have to go to dialysis or perform dialysis each night with the peritoneal dialysis. And generally speaking, patients feel better because they have a kidney, they have good kidney function. The disadvantage, however, is that it is not a cure. And what I mean by that is that if you have appendicitis and the surgeon takes out your appendix, that's a cure. Typically, you never have to go see the surgeon again. You don't have to take medicine. It will not act up again. That's what a cure is. Kidney transplantation is not a cure. Despite the fact that you get a new kidney, unfortunately, in overwhelming majority of the cases, unless you have an identical twin, you need lifelong immunosuppression. The kidney can reject, and it can be lost due to the rejection or infection. And because of the immunosuppression, patients are more susceptible to infections, to cancer. And the other thing is that there's limited availability. Currently in 2025, there are 90,000 patients on the waiting list for a kidney transplant. So unless you have a living donor, people are going to have to wait. It also requires a specialized medical facility. Many of you are used to that because amyloidosis are usually treated at a specialized medical facility with expertise. Similarly, this is the case with kidney transplant, where you need to go to a specialized medical facility that does kidney transplantation. And then finally, not everyone is a candidate. One thing that I want to share with you is that we do not take the native kidneys out. So as you can see, in this patient, the 2 top kidneys are their own. However, 2 additional kidneys have been placed, and there are patients that have 4, 5, even 6 kidneys walking around. Like dialysis, there are different forms of kidney transplantation, and we will go over these in greater detail. There's the deceased donor kidneys. These are the ones that you go on the waiting list, and you wait for a person to die, who then donates the kidney. There's a living donor kidney transplant, and under living donor, there's the directed donation, paired exchange, and what's called the chain. Now, obviously, the living donation is much more advantageous. The waiting time is a lot less. In certain parts of the country, the waiting time now is 5 to 6 years for a kidney, and this substantially cuts down the waiting time. The kidney transplant can be scheduled, so it can be scheduled around different events. Patients may be getting treatment for their amyloidosis. Patient may be getting other things, and for a living donation, this is scheduled just like you schedule a haircut. Whereas on a deceased donor list, when you get a call, you only have a few hours to get to the medical center to get that kidney. So it's, again, much more flexible. The outcomes are generally better for living donations. There's a number of reasons for this, but one of the reasons is that there is less time on ice. So if you get a deceased donor kidney, the kidney is generally harvested and then flown to you because it's usually not in the same town, which means that the kidney had to be preserved on ice. And the longer that it's on ice, the more injury that it can accumulate. So, so one of the reasons living donation is better is because of that. So what is required to donate a kidney? Obviously, the first and foremost, especially in this country, is the donor has to be willing, and it should be without any undue influence or coercion to donate. The kidney, the donor obviously have to have good kidney function, and they have to have 2 kidneys. There are conditions such as patients born with 1 kidney, or this condition called horseshoe kidney, where the kidneys are connected. Though these patients cannot donate because we cannot separate these kidneys. And then in general, the donors have to be in good health. They cannot have diabetes, they cannot have cancer. We do accept hypertension if it is well controlled with 1 drug. And then finally, they have to have compatible blood group types. So they don't have to be identical, but the donor has to be able to donate blood to the recipient. And then finally, the donor cannot have, or the recipient cannot have specific antibodies to the donor. So if the recipient has antibodies against the donor, then that kidney won't work. So what do we do in those cases where you have a donor, but they either are not your blood, they do not have a compatible blood group, or you have a antibody against them and making the kidney transplant not feasible. So there are different ways around this. There's something called the pair exchange, where patient A has a donor, but he or she is incompatible with the donor. Patient B has a donor, and it's also incompatible. Well, what if the donor from patient A is compatible with donor B and donor B's donor is compatible with donor A? Then they can do an exchange. So the donor from donor A will donate to recipient B instead, and the donor for recipient B will donate to A. And that's pretty easily done. The transplant center will arrange for that. But there's something even more complicated called the chain. And the chain is good because, as the name implies, they can keep going. So what happens is that, let's say there's a donor A. Donor A wants to donate a kidney, donates to patient B. Now, patient B has a donor that is incompatible with donor B, but because donor B, patient B received a kidney, his or her donor can donate to someone else, and their donor can donate to someone else. And as you can see, this is perpetual, and it can keep going. I think the longest chain reached about 16 patients. So because one donor started this chain, many patients can get a kidney because of this. So chains are a very powerful tool to match up patients and donors that do not match their friend or family, but they can donate to someone else and keep the chain going. So this is what a kidney transplant looks like, or actually this is what a donation looks like. Donations are now mainly done laparoscopically. There are these laparoscopic ports that go in, and then they have one big port over here, and that's where the kidney comes out. And then at the end of this all, this is someone who posted her picture on the internet. So as you can see, the left picture is pre-donation. Post-donation, 10 days, she has that one bigger wound that the kidney came out, and then a couple of side wounds where the ports are. And then this is 6 weeks later. And generally speaking, these scars actually go down even further. So these scars are not bad at all. What are some common questions? So what happens if a donor develops kidney failure? This is very concerning for many patients. Well, you know, especially if their children are donating to them, what happens if they develop kidney failure? Well, in the United States, any donor who develops kidney failure would go straight to the top of the waiting list. So they basically would get a kidney within weeks to months. Who pays for the medical costs of the donor? Again, in the United States, the medical costs of the donor evaluation and the surgery is paid for by the recipient insurance. So once the recipient is approved for a kidney transplantation, then the cost of the evaluation and surgery of the donor will be covered by the recipient's insurance. So the donor's insurance will not get billed for that. Just a quick there are still some patients that come to me and say, oh, my doctor told me I cannot get a kidney transplant because I have amyloidosis. This is actually not true. Now, again, I said that not everyone is a candidate for kidney transplantation, but if you are a candidate for kidney transplantation, then the amyloidosis does not exclude you. This is a study out of the Mayo Clinic. The lines are a little confusing, but what I want you to see is that the blue line, which is top line, are patients who achieved a VGPR or CR. I think you guys are familiar with these terms, very good partial response or a complete response after treatment. And as you can see, they do quite well after kidney transplant. The ones that do not do well are the ones that are either only had a partial response or no response at all. They do not do as well. And in our hands, as you can see, there's a major difference between patients who only had a partial response going into kidney transplant, or those going into kidney transplant with a very good partial response. The patient survival for those with a VGPR or CR, basically over 90% at 5 years. Compare with those with a partial response of only 37%, you see that we really do not want to transplant patients who can only achieve a partial response before kidney transplantation. And not only does the hematologic response at the time of kidney transplant affects the patient's survival, but it also affects the graft survival. Again, at 5 years, the kidney allograft, the kidney transplant survival is greater than 95% in patients that are VGPR or better. But again, it's only it's less than 40% in those with PR or less. This is confirmed by a multi-center study by the International Kidney and Monoclonal Gammopathy Research Group. This multi-center study was conducted over 5 countries and 11 centers. We collected 237 patients over a period of 33 years. The median survival, median follow-up of these patients were 8.5 years, and the graft survival was about 8 years. So you see that the kidney allograft actually did quite well, and patients that were transplanted later actually did even better. What we showed was that we could not tell the difference between VGPR and CR, but again, we showed that those who had only a partial response did much worse. And that's it, and I'll take any questions.
That was great. Another optimistic presentation. I love it. Thank you so much. That was super. And I would imagine now that that more patients are being treated with Daricitabart, we'd probably see, if you were to redo that graph, it would probably even improve even more.
Absolutely, I think so. Remember that study was done over 33 years. Many of those patients were treated with stem cell transplant and melphalan-prednisone and melphalan-dexamethasone. So with the newer therapies, those survival will no doubt be much better. And we're already seeing it at our center, that patients that are treated with the newer agents definitely have much better survival and outcomes.
Thank you. Okay, we're going to get to Q&A in a minute, well, 5 minutes probably, because we're going to hear all about financial aid and any other updates from our Paula Schmitt. So Paula, take it away.
All right. Good afternoon, everyone. Today we'll be talking to you about the different financial assistance programs that are available to help offset some of the out-of-pocket expenses that you may have due to your diagnosis of amyloidosis. Next slide. I have listed several different charitable foundations who offer assistance programs that can help with copays, deductibles, premiums, diagnostic testing, and even some travel costs depending on the particular program. The eligibility criteria and grant amount for each of these programs is different, so you will need to identify which one will best suit your individual needs. I have listed off to the right side of each foundation the federal poverty level threshold percentage that is used as their criteria. For your convenience, I will post a link, I already have actually, in the chat to our financial assistance flyer, which contains a lot of information on each of these programs. What you will learn today is these programs open and close several times each year based solely on the funding they have available at any given time. I'm happy to report that out of the 7 funds I have listed, 4 are currently open for AL and 2 are open for myeloma. To qualify for the highlighted patient financial aid fund that is offered by I don't have it highlighted, I'm sorry. Right here, the patient financial aid fund that is $100. You have to have myeloma along with AL in order to qualify for that, or another type of blood cancer. It can be a B-cell lymphoma, it can be Waldenstrom's, any other type of blood cancer, and you qualify for this $100. So don't let that sit out there. If you could use $100 to help buy groceries or go out to eat, you can do anything you want to with that money. Okay, next slide, please. As of Thursday, when I did these slides, the Patient Advocate Foundation, right here, their myeloma fund was closed. I'm happy to say that as of yesterday, it reopened. So that's the reason to check often on these funds, because they're closed on Thursday and open on Friday. NORD has 2 funds for amyloidosis that are currently open. And at the bottom of the slide, I have also listed the Janssen, the J&J with Me savings program that can reduce the cost of your drug if you are on commercial insurance. If you have government assistance, any type of government financial assistance, you would not qualify for their savings. They have a copay card. You would not qualify for that if you're on Medicare. But if you are on commercial insurance, you can contact J&J Me Savings Program and see if you can get signed up on their copay card if you have a large copay for your daratumumab. Keep in mind also that most of the pharmaceutical companies normally provide some type of financial assistance program or copay cards, depending on the type of insurance coverage that you have. And I'm not just talking about your amyloid treatment drugs as far as this goes. This also applies to other supportive therapies like Farxiga, Jardiance, Eliquis, or any other newer prescription drugs that you may be taking. Drugs that have been around for many years have generic alternatives and generally no longer have these assistance programs, but the newer drugs typically will have them. So do contact or go to the website for the drug manufacturer and check to see what they have available. Next slide, please. Caregivers. What would we do without them, right? The Healthwell Foundation has now set up an oncology caregiver behavioral health fund. It offers assistance with prescription drugs, counseling services, psychotherapy, and transportation costs needed to treat or manage behavioral health issues for a family member, providing live-in family care to a cancer patient with an active Healthwell grant. Now, I have not called them and asked if amyloidosis falls under their definition of cancer or not, but if you're interested in this fund, I would contact them and try to see if it does apply. But for those of you with myeloma, yes, it would apply. Now, your patient does have to be an active grant recipient from Healthwell in order for you to be able to possibly qualify for this fund. You also have to fall under the $500 federal poverty limit. And as I have on the slide, they are accepting phone applications only for that. Now, NORD, they have their caregiver respite fund, which will pay for a caregiver to come in to your home and watch your patient while you, the caregiver, go off and do whatever you may need to do, whether it's go to a movie or go to a wedding or go to whatever. You know, you are able to get out of the house for a little while and your patient is cared for by either a professional caregiver or someone who just says, I'm willing to come over there and stay with them. But they need to have somewhat qualified to be able to care for a patient. Next slide, please. This slide shows you the 2025 federal poverty levels. And each of these individual foundations set their own income limit. Most are set at 500%, but others vary in between 300 to 600%. Let's use the Healthwell Foundation as an example, since they have a fund that's open. You are allowed to make up to 500% of the federal poverty level. So you're going to go here and look down at the line that matches the number of people in your household. Let's just say there's a husband and wife in the household. You are allowed to make up to $105,750 per year. If you live in Alaska, Hawaii, or a large metropolitan area with a higher cost of living, the annual income amounts allowed are larger. And to find out exactly how much more they allow for the metropolitan areas, you'll need to call that foundation to see what their limit is. I don't know if it's the same as, say, Alaska or Hawaii, but you can see how much more they are allowed in Alaska and Hawaii at the 500% level. So call the particular foundation you're interested in and ask them to see if you are close to that threshold cutoff. Next slide. So what do you need to do now to better your chances of snagging a grant if the fund that you want is closed? Most of these funds have an email wait list where you can sign up to receive the notifications when the fund reopens. That is why I found out about that fund that reopened yesterday, because I was signed up for the notifications. Once that happens, you want to apply as soon as possible because there's a lot of competition for these grants and a fund can close again at any moment. You may want to keep your previous year's tax forms handy because you might need that info from them when applying for assistance. I also suggest that you sign up for the PAN Foundation's Fund Finder program, which is shown here on the screen. They will email you when one of the funds opens up. You go into the Fund Finder and you tell them you're looking for amyloidosis funds. And that way you will be able to receive an email when one of those opens up. You can also go directly to this website and check to see which are currently open. Now, when this slide was, when I took the screenshot of this slide, the only fund that was open at that time was with the Leukemia and Lymphoma Society. This is not a current slide. They are not open at this moment. So don't think you can go to Leukemia and Lymphoma Society right now. This is just an example. But when a fund is open, you will see the green lock is open. If the lock is red and closed, the fund is closed. But you click on each website or click on each link over here, and it will take you directly to the website of the one that is open. Now, if you have any questions about what I've discussed today, you can email me at paula@amyloidosissupport.org. I have that posted in the chat as well. And we will actually send out a copy of the chat to all of the participants today. So you don't have to try to struggle to get all this stuff copied. I will send it out to you, send you a whole copy of what was included in the chat today. But I thank you very much for your attention, and get out there and try to apply for a grant because there's 4 open right now, and that does not happen very often at all. So jump on it when you can if you could use some assistance funds. They come in very handy and are truly a blessing. Thank you.
Thank you, Paula. Money, money, money. Wonderful.
Yes.
And Paula, didn't the Leukemia and Lymphoma Society change their name recently? Blood Cancer United or something?
I don't know. I don't remember that. They may have.
They're in the process. I don't know what is the day, but it's within the month. If they haven't already, yeah.
Okay.
Okay, thank you. Okay, let's have the your videos on Dr. Vescio, Dr. Landau, and Dr. Leung. We're going to do some Q&A now, okay? Lots of questions sent in, and I promise you folks that if we don't get to all of them, because we are running a little behind, what's new? This is the Amyloidosis Support Group webinar, right? So we will send out these questions to our physicians and ask them to be kind enough to, take some time and answer them. By the way, here they are giving us their morning for our patients, and we do appreciate this. We don't take any of you for granted, and we know how special you are, just so you know. Okay, well, we do take you for granted, but you know what I mean. Okay, Dr. Landau, can we see your video too? Okay, here is a question. Okay, and we'll give this one to Dr. Landau. This is after a 3-year period of no therapy following 2 years of mainly DARA and DEX. How long is it possible to still need no further therapy? No repeat bone marrow biopsies have been taken, and the neuropathy and chronic kidney disease are unchanged. So what is your thoughts there?
I think Dr. Vescio explained it very well. So with DARA-based therapy, even after 5 years, 60% of patients have not relapsed. So I don't think I can predict for any one individual, but the good news is if you're 3 years out, and things have not changed, that is good. And I can never predict for longer, but you just need to be followed by your oncologist, and they will probably be able to determine that you are relapsing way before you have any insult and any further organ deterioration, hopefully.
Great. Now, question for you, Dr. Vescio. This patient has had 2 opinions. Okay. In 2008, she had a stem cell transplant that lasted 10 years. Then she had another one in 2018 that also put her in complete response. But this last 5 years, she's been on DARA, and then she obtained a complete response after the first injection and is still in complete response to that. Okay. And so, her one physician says that she should just be happy to stay on the DARA, and the other specialized opinion said that she could go off the DARA. So you're the third opinion. Should she stay on it? Should she go off it? What should she do?
Well, this is where, as Dr. Landau stated, it becomes a little bit, there isn't a right answer because none of us are so smart we can predict the future. I generally keep people on a treatment that's not bothering them if their disease has relapsed. So, it's already come back, twice now. And so what that tells me kind of simplistically is that your own body's ability to kill whatever cells might still be in there and hiding isn't there without some help. So the daratumumab kind of helps your body see whatever's left. And so I would tend to do it for quite a long time, a minimum of 2 years. And frankly, I have people doing it much longer than that because they come, they get their shot, they go home, they have some lunch nearby. We talk about the vacation plans, and that's kind of how I look at it. But I know it could be a lot more inconvenient than that. But so that I would tend to continue it. But
Well, thank you, and that was a very inexpensive third opinion. Okay, now, this is something we haven't discussed: IgA and IgM. And this person says their IgA and IgM are still in deficiency phase, and no improvement after stopping daratumumab for 10 months. Is there a hope to see the improvement, or just live with it? So, what symptom would someone see if their IgA and IgM are deficient? Dr. Landau.
Yeah, oftentimes we do see this again because these drugs are very powerful against plasma cells, both normal and abnormal plasma cell, even off the daratumumab. I tend to not worry so much unless patients are having frequent or severe infections. If patients are having frequent or severe infections, there is something called intravenous immunoglobulin replacement therapy that we can often give, whether in patients with plasma cell diseases, whether patients have low immunoglobulins or not. If patients are having frequent or severe infections, that is a typical strategy to prevent that. Otherwise, sometimes patients have deficient immunoglobulins and never get infections, and those patients can live with it.
Thank you. Okay, Dr. Leung, here's a patient that is on dialysis, very healthy prior to amyloidosis and dialysis. now he has a lot of muscle aches, tightness, and cramping in his feet and legs, and he's wondering if this is just due to amyloidosis in general or his poor kidney function and the dialysis. So what are your thoughts on that? You're on mute.
Cramping is a very common, unfortunately, side effect of end-stage kidney disease, and patients on dialysis often experience cramps. There are some medications that can be used, but it depends on the cause. So if we, a lot of times, if we get the weight a little too dry and we remove too much fluid, cramping will occur. But other times, patients will have leg cramps, and even something called restless leg syndrome as a result of the dialysis. And this is one of those things where dialysis just won't solve. These go away when the patient undergo a kidney transplantation. But they, again, they should talk to their dialysis centers. Dialysis centers are usually quite knowledgeable about this because it's a very common thing. But there's you can try. We used to try quinine, but that's no longer available. But there are certain muscle relaxants that can be tried, and make sure that the dry weight is appropriate for them. But yeah, this can be a frequent problem that patients with dialysis run into.
What about the old pickle juice or pickles or soap under the bed?
Well, I certainly have patients that are on pickle juice. The problem with pickle juice is that on dialysis, that's a lot of salt for patients who are on dialysis. And so I generally have patients try pickle juice if they have fairly good kidney function and they're not in heart failure. So it gets a little tricky. I also have patients take, about 2-3 ounces of tonic water. That can help, but they have to get real tonic water and not tonic flavored water. Tonic water contains quinine, and for some patients it definitely helps, but they have to make sure that they don't have a reaction to quinine. So quinine, 2-3 ounces isn't very much. You might be able to get by with just 1 or 2 ounces of quinine. It doesn't work for everyone, but it works for over half the patients.
Great. It keeps malaria away, right? Or something.
Yes.
One more question for you here before we move on to another. Okay, on taste buds. Jim has an issue since spring 2021. His taste buds are problematic and affecting his quality of life. He's on peritoneal dialysis, okay? And and he has a pacemaker. And so his taste buds are terrible. All food tastes bad. He sustains himself on Nova Source. The only food that he eats occasionally is bacon and orange juice. All his doctors are puzzled by this. And so what are your thoughts on that?
So altered taste sensation is usually a sign of uremia, which is the toxic condition that is treated with dialysis. Generally speaking, most patients' tastes will improve once they go on dialysis. And it doesn't persist as much. So I wonder if it's not, I wonder if it's another drug that may be doing this, because it's not a common thing that occurs in our dialysis patients once they start dialysis. And then, of course, COVID had altered taste sensation for many patients. And so, and even the strains last year, some patients have lost their taste. So I don't know if that could have been related, but it's not a common thing that occurs in our dialysis patients once they've started dialysis.
Okay, great.
It-
Okay, all right, this one was handled by Dr. Landau in a presentation about organ improvement. I think you covered that really well, and also Dr. Vescio. Okay, first there's a question on centers of excellence, and since all three of you are, interested at centers of excellence, this person would like to know what the parameters are for assuring a patient will be accepted for transfer to a center of excellence. Now, you're all three at completely different hospitals. This person wants to know is there any reason why your centers would deny a patient access to you other than the fact that it might be an insurance issue? But outside of that, can you think of any reason why a patient would be refused to go to your center if they were at a like Podunk Hospital or whatever?
It is usually insurance. There's with especially like transplants and things like that, there's a negotiation by the administrators with the insurance company to charge a certain amount, and if it's higher than they want, then they're not allowed. Occasionally, some centers, if their outcomes aren't as good, then the insurance companies will say, well, oh, the patients don't tend to do as well at that place, and so they'll forward patients to somewhere else where their outcomes are better. But it's mostly insurance.
That's kind of what I thought. Dr. Leung, Dr. Landau, do you have anything to add to that?
No, I think that's usually the culprit.
Okay, I have a few cardiac questions, and even though I know that none of you are technically cardiologists, I know that you have to play cardiologist on occasion. So this one wants to know, please advise of a procedure or a pill other than a heart transplant that might alleviate or cure my heart condition. I'm in remission on my multiple myeloma. My ejection fraction is down to 33%. And what institute might perform this? So can you think of anything other than, a heart transplant or that would help their hearts? No? Yes?
So, do they have amyloidosis? Because
Yes.
if they have amyloidosis, it's treated quite differently. The cardiologists have been using a lot of SGLT2 inhibitors lately. Although there hasn't been a formal trial, the experience seems to be pretty good. They're well tolerated. They help the heart function. They can help preserve the kidney function.
Is that like Jardiance and stuff like that?
Jardiance and Farxiga, those have been used quite a bit. It's used a lot more in the TTR world, but certainly in the AL world, it can be used. Now, the only caveat is that it does drop their blood pressure a little bit. So if they have low blood pressure already, they may not tolerate that. Beyond that, there's some might do something like spironolactone. As long as their potassium is okay, spironolactone can be helpful in the heart failure patients. Usually, it's really a very regimented diuretic program to make sure that they're in the right fluid status for their heart. And then for those that are, for a while we were doing these left ventricular assist device, but those are really for very advanced heart failure patients that are not eligible for heart transplant.
Gotcha. Well, while I've got you, this person has a question on resting heart rate. After completion of treatment with good response, do you see a tendency that the resting heart rate will move to lower range?
After what?
After completing treatment with good responses, do you see a tendency for the resting heart rate to move to lower ranges?
I think that's a complicated question because it depends on many things. So, for example, In fact, I have a patient right now in the hospital. They're in bed of heart failure, and their blood pressure is on the lower side and their heart rate is on the higher side. And as we treat the heart failure, the heart rate is coming down. But this is not something that, I think we can answer without seeing the patient, because there's so many different things that determine heart rate. And so it's even, this is even hard to even answer generally.
Okay, and here's a question. And Dr. Landau, we were discussing this, the durability of the CAR T treatment. And this person wants to know what the length of remission with Daracide tends to be on average. Do you have a response to that?
Yeah, so just from the data, the updated data that was presented, about 60% of patients at 5 years are still in remission. But, again, maybe some patients will stay in remission forever. We don't know. There's definitely some patients who come out of remission, and these newer therapies have been very effective for patients, but again, we don't have any durability data on the newer therapies.
Okay, Dr. Vescio, how many stem cell transplants can an AL amyloidosis patient have?
Well, I've had patients that have had 3, so I guess you can at least do 3. I guess medically there's no reason you couldn't do more. But I kind of wonder, the very first one, the person you talked about, it took 10 years and 5 years. You can theoretically do more, but we have such better treatments now that, if 2 didn't work, I'm not sure I would tend to think of a third. And they work less well every time you do it, generally speaking, because the cells that grew back somehow survived the first experience. So I would tend to focus on the new drugs, which I think are extremely effective and can work even when transplants don't. So
Yeah, this
Dr.
person wants
Landau's
to
treatment looks extremely good.
know.
I think they'll be in remission a long time.
Great. This person is, what is the data showing in terms of effectiveness and remission with the Cyber-D-Dara treatment versus stem cell transplant? And I know there's a clinical trial going on in Mayo. I don't know who else has it going on where they're doing a comparison finally, right? So, but we won't have data on that, I would imagine, for quite a while. So is there any other data that would show any kind of comparison?
No, it's really hard to answer that question because, and that's why we're doing the trial. It's a multi-center trial through a cooperative group of DARA VCD plus or minus transplant. Because it was 1996 when the first transplants were done, and that was the first treatment that got people into remission. We have the longest term data with transplant patients who achieved a complete hematologic remission in transplant, and some are 20 years plus out. So we have that data. Just because we don't have the length of experience with Daracide, we can't say that patients who achieve a complete remission won't last the same amount of time. We don't have that. I think that there's a good hope to think that some proportion of patients will last the same decades in remission after Daracide. We just don't know.
And that summed it up very good. I just want to say sometimes some patients may be early in their diagnosis. At the beginning, if people come in really sick, you can't just say, okay, we're going to do a transplant, because that can be life-threatening. And even the Daracide can be challenging. I've had people have a really rough time with just that, and that certainly is less likely to make people ill than a stem cell transplant. So that very beginning is the important one, and sometimes you have to tweak the medicines to hopefully have it work and to have people start to recover before you can do something more vigorous like a stem cell transplant.
Yeah, I'm combining three questions into one now for all three of you, and I'll let all three of you answer this. We have a patient who's been on Daracibor-D for 6 months, and they're not they're just in a partial response, not even a very good partial response. What would be your next step? Would you leave them on it and hope it will eventually work? Or are you going to put them on something else? And what are you going to put them on? And we'll start with you, Dr. Landau, and then we'll go to Dr. Vescio, and then we'll go to Dr. Leung, because I know that you also treat patients as a hematologist at the Mayo Clinic as well. So, Dr. Landau.
Yeah. So the first thing to consider is, do they have this translocation 1114? So the answer is no, I would not keep them on if they have a partial response and have, we like to at least get patients into a very good partial response and see some sort of organ improvement. 6 months, again, is early to see organ improvement, but with just a partial response, that likelihood is that the organs are not going to improve with that level of response. So I would change therapy. That's number one. Number two is if they have translocation 1114, the venetoclax is an oral drug, very well tolerated, and can be very effective for this group of patients. So that would be the second step. And the third step is, are they a transplant candidate or are they a clinical trial candidate for one of our novel therapies? So, and that's a hard decision. I do, my experience with, again, if they're a trial candidate, that would be my favorite approach. That's the only way that we're going to get these drugs to patients, and I think they're very effective, and I think we've had really good, we have favorable safety considerations and very deep remissions. I think that transplant is a very good therapy, but it's a bigger investment than some of these other drugs, actually. And we know it works, but the CR rates are only in the 30 to 40%, where with the newer therapies, they're upwards of they're more like 70%. So I do think I find, if somebody is a trial candidate for one of our novel therapies, that would be my favorite approach. I mean, venetoclax, then clinical trial, and stem cell transplant. If they are a transplant candidate, I would always collect their cells, but I wouldn't necessarily transplant them if they were a clinical trial candidate for one of these other very effective therapies that we're really hoping to get to market.
Okay, if you do the venetoclax, are you going to keep them on the Daracibor-D or in additional venetoclax, or how are you going to do that?
It really depends. I would never keep them on Daracibor-D. Sometimes venetoclax plus daratumumab would be my favorite approach. Or if they're not tolerating the it depends on what the toxicity profile is. Venetoclax in and of itself can be very effective. Often it's more effective with daratumumab. So if I could use them both together, I usually try that.
Very good. Dr. Vescio.
I think that was very well stated. I would agree with everything. I think the only kind of nuance is that it depends a little bit on how sick or how bad the amyloid was harming the person and how the overall health of the person. So if it was some protein in the urine and people felt well, maybe a little, swollen legs, but the amyloid really wasn't too harmful to the person, and the numbers are coming down, but kind of slowly, I will tend to just let them come down for such patients. But admittedly, because it can take a long time, but if it's come down and then now it's not, then I would start thinking of a new treatment. And especially if somebody was, and sometimes they're pretty ill from the amyloid, their heart was involved, their nerves are involved. Then you need to make that go into remission, and definitely would think about a new treatment.
Gotcha. Dr. Leung.
Yeah, I mean, I agree with both Dr. Vescio and Dr. Landau. I think that, typically after, we usually switch after 2 to 3 months if they didn't get to VGPR, and definitely at 6 months if they didn't get to VGPR, continuing the therapy is not going to be effective. So I kind of take Heather's approach. We always look for 11-14 first and see if that's there. And then, the next one is what Dr. Vescio is saying is how sick are they? Are they healthy enough to go through a stem cell transplant? That's always a possibility, but after 6 months, it could be either way. They could be sicker, or they could have been healthy enough. And in fact, Dr. Landau's done studies that showed that pre-treating with chemo actually help patients undergo stem cell transplant or tolerate stem cell transplant better. And then we would just, if they're not a candidate and they don't have 11-14, then clinical trial. There are, there are clinical trials with bispecific and CAR T, so try to get into one of those, because with amyloid they can't get CAR T or bispecific as soon as they could if they had myeloma. So if they don't have myeloma, that's the only way that they can get it before the 5th line. And then just the standard myeloma therapy. So Dr. Gertz here uses a lot of mini BRD, and that can certainly work. We've had good experience with that. But it
What
really
is that?
Velcade, Revlimid, dexamethasone, so myeloma therapy. And I think that that's one of our go-to. There are some patients can't tolerate the Revlimid as well, but for those who can, they can get some good responses with that. But it really comes down to the patient. How healthy are they? Are they able to tolerate some of these therapies? What organs are involved? So it's not a it's really an individualized answer for most patients. That you can't really answer this for everyone, because amyloid patients are so different.
Okay, great. Thank you. Okay, just have a few more questions, and what we'll do is, folks, if you typed in a question, we'll get those to the physician so that they can answer them via email, and they'll send back the responses to me, and then I'll send them all out to you. So meanwhile, though, you have 4 more here. I appreciate you staying on, because I know we promised you we'd be done on the hour, and we're just going to go a few minutes over. Here's a lifestyle question. What kind of lifestyle to keep patients healthy are recommended? Will answers from AI be good enough to adopt? Who wants to take a lifestyle question? Dr. Vescio, you're in California, known for its lifestyle. Why don't you answer that?
Well, I think generally what's good for the body is what you should do. So, keeping your mind sharp by doing things, and keeping active to keep your body in good health, and obviously eating food that we all would know is good for us. Some of these things where people had their transplant and then 10 years later they had another one. You had to you can fix the amyloid, but if you don't prevent cardiovascular disease, you don't prevent diabetes from getting to you. So things like that, can't be ignored. Sometimes the focus is only on the amyloid. So I think I'm not sure that I think the AI isn't necessarily going to be the most helpful for diet and exercise advice, but I think it's helping us under when somebody has a symptom or somebody has a problem, we can use AI to make sure we're knowing how to recognize things and treat people the best. Yeah.
Thank you. All right, we covered this question a little bit, but we didn't, maybe there are some people out there that don't know what MRD is, okay? So I don't know if we use the term minimal residual response that much today. So Dr. Landau, can we go into what are your thoughts on MRD? Maybe you can explain what it is for those that don't know. And if you've had a very good partial response or tested MRD positive, should treatment be continued striving for MRD negative? Is that the answer to everything?
Yeah, so minimal residual disease or measurable residual disease is a term that we use. It has become important in patients with multiple myeloma because we have lots of data to suggest that it correlates with outcomes in that population. We're generating some data in patients with amyloidosis. What it means is that can we detect any residual plasma cells in the, what it means at this moment is can we detect any residual plasma cells in the bone marrow that may be amyloidogenic. And with very sensitive techniques, meaning flow cytometry or next generation sequencing. And if we can't, meaning if you are minimal residual disease or measurable residual disease negative, does that predict better outcomes? And that is the case in patients with multiple myeloma. It just means the patients who get the deepest responses really stay in remission for a very long time. We expect that will be the same in patients with amyloid, but we don't know if you actually, we all have patients who get a very good partial response and organs improve, or patients who need a deeper response for their organs to improve. And we're trying to figure all of that out right now. It's probably an important characteristic and it probably predicts for better outcomes, but does that mean everybody needs to be treated to the level of MRD negativity? Probably not, but I don't have we don't have enough data to suggest who are the people who do and who are the people who don't at this juncture. If for an individual, if you have achieved a level of VGPR and your organ is getting better, then that may be the level of response that you, for your disease, for your light chain toxicity, is enough for you.
Thank you. Anything to add, Dr. Leung, Dr. Vescio? No? Okay, great. Okay, person has a lot of issues, but we'll take, okay. First of all, diarrhea related to bortezomib, Darzalex, and okay, Daracibert-D. Has diarrhea every single day, takes Lamotil every 6 hours. They're now malnourished. Cholestyramine makes it worse. They're going to Banatrol plus. Any suggestions on diarrhea? And is this a fairly common thing that happens? Well, Dr. Vescio.
Well, the first question I would have would decide what to do is what was the diarrhea bad before any treatment was started, because there are people with amyloidosis where that's how they present. So therefore, then you got to fix the amyloidosis before the diarrhea is going to get better. Tincture of opium is things, believe it or not, that I've occasionally had people do when it's really bad. But if it wasn't so bad and now it is, then it's likely the drug, and that sounds like terrible diarrhea. So I would tend to stop the bortezomib because we have all these other options, and that's most likely the one doing it. It also could be another reason. It could be an infection, like C. diff or something like that. So that severity is bad enough where you can't just go, that's not livable. So somebody's got to figure out the reason and then figure out what to do about it.
Any additions to that? No, okay,
Agree wholeheartedly.
okay.
Yeah, I think I totally agree with Dr. Vescio. I think that, it's very unusual for someone to have diarrhea every day from chemo. Diarrhea from Velcade is pretty common, but it's usually for a day or two. To have it every day, I think that something else may be going on, and they need to try to see what the real cause is.
Okay, this person's low on albumin, third spacing. I have no idea what that means, but I know you guys do. Building up fluid in leg, arms, face. Can't take diuretics because his blood pressure is very low. Compression socks aren't helping. Abdominal binder isn't helping. They've ordered leg wrapping, but it hasn't happened yet. They take midodrine, fluorocortisone. Okay, is there anything else that you can suggest they take? They take Lyrica for the body pain, and they sleep a lot and have no energy and get dizzy a lot. That's so sad.
So, there are a few patients that are resistant to everything, but there are really rare. For me, midodrine works for a lot of people, and then if I add Florinef, it works for a lot more. There is one more drug that they can try, and that's called droxidopa. And that can help, but it also sounds like that this patient may benefit from getting some albumin infusion, at least to temporarily get things going, get some of that fluid off. It can temporarily raise their blood pressure a little bit. It's not a long-term solution, but for short-term, we have used that to try to get the patient at least a little bit more comfortable, and hopefully by then the autonomic neuropathy will be improving from therapy, and they can have a little bit better blood pressure, but they can't tolerate diuretic because their blood pressure is so low. So the first thing is really to get that blood pressure up so that they can tolerate the diuretics.
Okay, anything to add?
Agree. If you're resistant to midodrine and Florinef, droxidopa can be kind of magic. It just takes some thoughtful, consideration for somebody to consider that, and then you can get. I agree with the albumin and diuretic for short-term control of this kind of issue as well, and then lymphedema therapy. Those practitioners who perform it, they can really, they're kind of angels and do magic as well. So all of those strategies, but again, they're not terribly mainstream if you're not taking care of a lot of these patients. So sometimes thinking outside the box is important.
And then the only other thing I would add is, hopefully this is at the beginning of their diagnosis, and hopefully the treatment worked really, really well. And if they're in remission, by the labs, then I try to remove drugs that could be contributing, and just hope they'll stay in remission. So the dexamethasone and the Velcade both can do the fluid retention. So if I've had people in 1 month, they're in remission, and so then you can be more confident about reducing some of those drugs. But that's the scenario we never want to see, is somebody presenting like that, because they're really sick, and you got to give them medicine to make them better, and it's going to take a while to get better. So yeah, it's tough.
We'll take one last question, and we don't have a neurologist here, so you're all going to play neurologist now, okay? But you've been doing really well with all the other disciplines. I'm very proud of all of you. So This is about neuropathy, and basically, how can you tell if a person's neuropathy is from if they had it from the disease to begin with, but they've also been on Velcade? How can you tell if it was a disease neuropathy or a Velcade neuropathy? Dr. Vescio.
That's where you have to go kind of by timing. Usually the Velcade neuropathy doesn't come on right away. It can come on later, like the third, fourth, fifth month of treatment. So if things were not good and then all of a sudden they're getting worse, but the labs for the amyloid, the light chains, are better, then I think it might indeed be the Velcade. But if it's been about the same and really hasn't gotten better, hasn't gotten much, if any, worse, then it probably is more the disease. But that can be sometimes hard to know, certainly.
Okay, well, I want to thank you all so very much for giving us your morning, and it's been in part of the afternoon for some of you, and we'll make sure that this video goes up on our website and YouTube channel in about a week or two, and we will get those other questions answered that you typed in, not to worry, okay? And you Chicagoans, we've got a meeting coming up at Loyola September 20th, so I'll see you there. I want everyone to stay safe. I can't thank you all enough again. Thank you so much. It's summertime. I know you have a lot of family outings to go to, and here you are with us and our patients. Remember, everyone, to stay safe. We're only a phone call away, but try to make it during a daytime phone call if you can. Okay, and don't forget the survey when you leave, and stay safe, and thank you again, everyone.